Good morning, everybody. Welcome to our webinar sponsored by BrosMed, excellent company producing interventional tools, very well known for their latest balloon technology. So today it's my pleasure to have a distinguished panel, and we're talking about specialty balloons in complex PCI, clinical strategies with BrosMed. And I want to introduce Dr.ssa Anita Paggi from Italy. She's the head of the cath lab in North Milano at the Ospedale Bassini, with over 15 years of experience in interventional cardiology, many thousand PCIs as first operators, including complex PCI and CTO PCI. She has also high procedural experience in left atrial appendage closure, impeller-supported PCI, and TAVR. She's also a faculty member of the leading international congresses GZ Toby and CTO Chip Summits. She's an active investigator in many trials and has extensive experience in the field. Then we also have Dr. Olli Kajander from Finland with us today. He's a consultant cardiologist from the Department of Tampere at the University Hospital in Tampere in Finland. He's an adjunct professor in cardiology. He's the head of the OCT Research Core Lab that you're probably familiar with from very famous OCT trials such as October Total OCT and Ischemia OCT. And he also holds a PhD from the University of Tampere in Finland. And last but not least, Dr. Ioannis Tsiafoutis from Greece. He's an interventional cardiologist, director of the cardiology clinic in Athens. He's the past president of the working group of the interventional cardiology in Greece. He's a proctor in complex PCI, well known also for his CTO PCI meeting that, if I'm not mistaken, was just last week, actually. And he has over 100 publications in the field. My name is Gregor Leibundgut. I'm from Switzerland at the University Hospital in Basel. I'm the director of the CTO Chip program here. I have also done extensive basic science research in lipid, which was like my previous life. And I'm now a board member of the Swiss CTO community, founder of the CTO Chip Summit, as you're hopefully familiar. And with that, I want to lead to the agenda of today. Myself, I'm going to start with a talk about proximal optimization, stent expansion, apposition in large bifurcations, especially about the POT PTCA balloon, which is famous from BrosMed. Then we have a small discussion. And after I invite Anita Paggi from Italy, talking about scoring and POT, the right tools for good PCI. So she will dwell a little bit more in the POT balloon technology. Then we have Olli Kajander from Finland talking about the cutting balloon of BrosMed, the RevoEdge, deliverable high performance cutting balloon for complex lesions. And finally, Ioannis Tsiafoutis from Greece will talk about useful tools, special microcatheters, and as well about RevoEdge balloon for complex PCI. And he will especially focus on cases. And we then have a final discussion before we all have to go back to work. So without further ado, I will start with my talk about proximal optimization, stent expansion, and apposition in large bifurcations. I want to show a little bit from bench to bedside. This is Olivier Darmon, very well known French interventionalist, and he is called Mr. Pot. He was initially suggesting and introducing the technique about proximal optimization of bifurcation lesions. And when we look at bifurcations, it's always important that we speak the same language. And therefore, I just want to briefly touch on bifurcation nomenclature. And that also a little bit show you that there is angles and geometric relationships involved. So we have a proximal main branch. In the Medina classification, this is the first number. Then we have a distal main branch. That would be the second number. and then we have a side branch, which would be the third number. And then we also have an inflow angle, that you can see here from the proximal main branch towards the bifurcation plane. And then we have a carina and outflow angles between the two branches. And these are called the bifurcation angle. So whenever we talk about a shallow bifurcation angle, this B would be a very small number, usually below 70 degrees. And if it's a wide bifurcation angle, then it would be a very large number. We are never talking about A and C. Then finally, there is this polygon of confluence. This is the area where the three tubes meet. And this is a geometric complex structure. And that's a little bit why we need to do kissing balloon and pot optimization. That's what my talk is also about. What goes in comes out. So flow in is equal the sum of the flow out. And if you count that down to the diameter of the vessels, which is more comprehensible for us, we can finally break it down to the Finney law, which is quite simple. This number 0.678 is actually exactly 2/3, which is even easier to calculate in my head. So whenever you want to know the diameter of a left main, it's basically the sum of the distal vessels. So let's say this would be an LED 4.0 millimeter, and the circumflex also maybe 4.0. You have 8, and 2/3 of it would be 6. That's why we need to have NC balloons going up to 6 millimeter. Of course, imaging is very important in bifurcations, especially in large bifurcations, but here you can have a very good estimate of how your devices have to be. When we dwell further into the bifurcation and the branching law, then we're talking about fractal geometry of coronary bifurcation. This is because the flow in equals the flow out, and this is different in a street bifurcation, where it's not the flow in equals flow out, but it's the diameter of the street, which stays equal. So your boardwalk is in line on the side branch, basically. And this is very different in anatomical bifurcations or bifurcations of tree trunks and branches. Here you can appreciate that the flow is conserved, and therefore your side will increase or step in, and your carina actually sticks in to the vessel a little bit. And this has very important implications when you start stenting bifurcations, because you want to conserve the area or the position of this bifurcation and of the carina. When you look into the vessel with OCT, and this is Olli's topic later on, here you can appreciate that the side branch is going down. This is the black hole, and the carina is actually almost in the middle of the vessel, indicating that the proximal vessel here and distal vessel, you can appreciate the carina, are about twice as big as the two branches in the distality. And the smaller the side branch becomes, the more offset the carina will be. What we all also have to be aligned is the nomenclature of stent architecture, so that we all talk about the same thing when we start embarking into stenting bifurcations. And here, just illustrated, you can appreciate in yellow the rings or the hoops. These are responsible for radial strength of the stent. Then we have connectors that longitudinally connect those rings. Usually the modern latest generation stents have 2 or 2.5, sometimes up to 3, but 2 connectors is a little bit state of the art today. Then we have crowns, and the more crowns you have, the more overexpansion capacity of the stent there is. And this is important for bifurcation stenting, especially for the proximal vessel where you do pot overexpansion. Then we have side cells, and in open cell design, these cells are really large. So you can easily cross into side branch, open the side cells, and have a very nice bifurcation stenting. And we have the strut length. Again, the longer the overall length of a ring, the bigger the overexpansion capacity. And finally, the strut thickness is responsible for radial strength. And here you would like to have very thin strut stents around 85 microns nowadays, to have less turbulence and better outcome long term. So how do we proper stent, and how do we measure the stent diameter? Again, we are sizing our stent according to the distal reference diameter. This can be achieved angiographically, but of course, much better is intracoronary imaging. And then you end up, by definition, because of the branching lobe, with a malapposition on the proximal end. This can lead to stent thrombosis, in-stent restenosis, longitudinal stent compression if this is an aorta osteal lesion, and rewiring behind struts. And here's just an example of a left main stenting with an underexpanded malapose stent. And especially when you have a jailed wire, by definition, when you push a guide, you will have a longitudinal stent compression. And in some designs, the stents actually collapse luminal and cause an obstruction and turbulence. And you can appreciate that this result would lead most likely to an acute or late stent thrombosis. What happens if you put a stent too big? So you oversize the stent, or you size it according to the proximal vessel. Then you would probably end up with distal edge dissections, which can be flow limiting and are also prognostically relevant. And you will shift your carina, and in the worst scenario will occlude your side branch due to carina shifting. Therefore, we do size the stent according to the distal reference diameter. And then on the same wire, which is by definition luminal, we would advance a second bigger balloon, and ideally a PCI balloon, which is sized to the proximal vessel size. And we will expand it very close to the carina, not cross-distal, because we do not want to shift the carina, and then post-dilate and oppose the stent to the proximal vessel. And here's a small bench test that shows a bifurcation with two same-sized distal vessels. And you can appreciate here I was doing several pot maneuvers. It's ideal to start proximal and then go closer to the carina. And you would not want to overshoot the carina in order for not to shift it. And you can appreciate how nicely the stent struts are now opposed. And the second benefit is that your side cells are opening, and it's much easier then to cross the distal cell after pot. First of all, you don't end up behind the struts, and second of all, you have a bigger space. Here with an old cipher stent, again, you can appreciate the malapposition on the right bottom side and the small side cell opening at the carina level. Here's the carina. There you can see the space in pink, which you have to cross with the wire, and the space in green that is malaposed and bears the risk of wiring behind. This is after the pot. You can appreciate that the wire space where you want to go to, the distal one, is bigger, and the apposition is complete, so no risk for wiring behind the struts. Overexpansion capacity is crucial and comes with all latest generation stents. Here just some examples. There's also a nice paper by Nicolas Foin and a follow-up paper with latest generation stents showing you how big you can overexpand these stents, still having enough structural integrity for radial strength and apposition of the proximal vessel. And you can also appreciate how big these side cells become, and it makes it very, very easy to cross into the side branch. What can go wrong with pot? As I said, if you do the pot too distal, it's like putting a big stent. You have overexpansion, you can end up with distal edge dissection, and most likely shift the carina and pinch the side branch. Proximal stent elongation is also something that has recently been out in the field, a published paper by Gabor. I'm not so sure if it's really true. It has a little bit to do with overexpansion of balloons and plastic deformation, but basically the paper states that when you do a pot, then your stent elongates a little bit proximally. That's why some operators suggest to do the pot proximal and then go distal. But this could happen, that your stent eventually overshoots and sticks out in the aorta. excessive elongation and may cause aortic protrusion. Just be aware of that. In the paper, he also published the OCT image where he nicely showed a elongation of the stent of about 30%. Maybe when you do your next pot, you do imaging, ideally with OCT, and you measure a little bit your stent length before and after, and make your own idea. It's not really a big issue, but it can happen. So then we pot it, and we do want to recross very distal to the carina. Why is that important? Here are 3 examples. The distal cell rewired on the left side is ideal. Mid rewiring is okay. Sometimes you cannot really target the wiring. And of course, you could check with OCT and then rewire, and spend all day. But at some point, you're just happy with what you have. And the pot really facilitates distal side cell rewiring. However, if you have a proximal rewiring or even behind struts, this is really bad because this ends up in stent deformation. And if you rewire distal, you will see that your stent opens nicely. Your carina is eventually metal-free, and you have a very nice covering of your shoulder of the side branch. And then you can put a second stent, if necessary, in a provisional fashion, just adjacent to it. And you have a very nice, perfect coverage of the side branch shoulder, but no neocarina and almost a metal-free carina. This would be ideal. If you rewire proximal and you do the side branch opening, then you end up in this scenario where the proximal, where the stent struts are deformed. All the stent struts are compressed towards the carina, and you end up with a lot of metal. And if you have to put another stent into the side branch, you have no coverage of your shoulder. You have to pull the stent backwards inside. You basically do a tap, and then you have a big neocarina, which can interfere later with the final pot. Or you then decide to cross over into a culotte stenting, but then you have to recross again, and you do a lot of work, which is unnecessary. What happens during side branch dilatation? You can appreciate that your balloon pulls the stent away from the main branch. It nicely opens the side branch and puts it to the shoulder. However, it pulls it away from the opposite side, and this has to be restored later. And here again, a bench test. You can appreciate that I recrossed or that I crossed into the side branch through a distal cell. And when you now open the balloon in the side branch, you can first appreciate how nicely the side branch cell opens up. However, on the opposite side, right there, if I let it run again, you can appreciate how much the stent becomes deformed and becomes pulled away. And when the vessel restores, the stent doesn't go back, and you end up with malapposition, a risk for stent thrombosis, and also instant restenosis because you have no drug there on the wall. You have the intima hyperplasia, and to fix that later is very cumbersome. Therefore, we have to push the stent back or hold it back. That's why we do kissing balloon. So whenever you do side branch opening, you have to think about deformation of the stent, and you have to restore it with a kiss. You would not see stent deformation in the angiogram. You have to image with OCT or a very high resolution IVUS to see that, but you don't need to see it because you know it's happening, and you prevent it beforehand with kissing balloon inflations. After you kissed, you potentially overlyze the stent in the proximal part. That's why after the initial pot, which is for apposition, better rewiring of the distal cell, you do a final pot. And the final pot is a little bit a problem when you have a tap with neocarina because you can deform your neocarina. Therefore, a final pot is done a little bit more in the back. Remember, you have done the coverage of the polygon of confluence with your kiss. You just want to reoppose and round out your stent in the proximal end. Therefore, the final pot is done in the back and not as close to the carina as your initial pot. And this is how it looks when you did ideal proximal optimization technique with contemporary stent platforms. and you can see that the scaffolding is extremely nice. I'm not going to talk too much about the pod PTCA balloon because I think the next speaker is gonna extend on that, but the balloon is specialized for pod procedure with a very short shoulder, so you can push your initial pod, I must say, very distal and close to the carina. And this is how it works on the bench with a balloon that has very long shoulders. You have to push the balloon very distal into the main branch. And you can appreciate if you compare to a pop balloon, which is more like a soda pop can, that you do not have a very nice expansion of the carina. You can end up with carina shifting, whereas on the right side with the pop balloon, you have better control and you open the proximal stent, but you do not touch the carina. And just to finalize, I have a small case, but I think we will see more cases. This is a Medina 011 lesion, which I decided to stent across the main branch. Then here you can appreciate the pod and the pod PTCA balloon. Then I recrossed in the side branch, and you can actually appreciate the deformation of the stent in the main branch when you would only open the side branch here on live stent, clear stent. So therefore, you need to do the KISS. It's absolutely crucial. This scenario, you have a small dissection in the side branch. Back then, I decided to put a stent. Today, I will probably leave this dissection, and I decided to do a T, reverse T or a tap. And then again, you do the kissing to restore the stents and to correct for the deformation. And then here, finally, the final pop is much more back proximal to not touch the neocarina of this tap procedure, to not deform the side branch stent. This is the final result. I think quite okay. And this is how I think you should do dual stent strategies nowadays, and the pop balloon is really helpful in this scenario. With that, I want to lead the discussion. So maybe there is some comments from my co-panelists.
Oh, can you hear me?
Yes.
Okay. That was, I think, a terrific presentation because it dives us through the way a bifurcation must be done nowadays. And I must say that, of course, bench tests are excellent for explanation. Of course, sometimes in real life, you don't have that much visualization, of course, of stent struts, etc., and the wiring. But of course, imaging is the best way to also check the wire position. But sometimes you don't, as you said, have that much time to do that again and again. So also tools like maybe stent boost, etc. Also in larger, especially larger bifurcation, allows you anyway to have a look at the distal or proximal wiring. And I also wanted to ask you, what do you think about leaving the jailed wire as a marker in order to visualize, for example, with the stent boost, the crossing of the second wire, and to see the distance between the two wires as a tool to have some confidence about wiring distal? Do you have do that? You use other methods?
Yes, thank you very much for your valuable comment. And I think this with the jailed wire is very important. Just with my case example, I did exactly that. So I usually leave the jailed wire in the side branch. First of all, to see the takeoff, like as you said, to have a marker. Second of all, it gives you also anchoring. So whenever you have to cross with the balloon, you can a little bit pull on the jailed wire, and it gives you some stabilization and anchoring. It's a different story in the left main, because there, of course, you can have longitudinal stent compression with your guide. And there I usually do a short check with contrast after I did the pot. If I have still flow in the side branch, which is the circumflex most of the time, I first place a fresh wire and then retract the other one before I do the recrossing. But that's just on the left main. Otherwise, I usually do that. Having said that, you have to be careful because the jailed wire is not where you want to recross. It will be pushed to the side, to the shoulder, as you know, of the bifurcation. And in large side branches, it can be 3-4 millimeters away from the carina. So don't chase the jailed wire. It just shows you the trajectory of the side branch. Think about the diameter of the side branch that you have to go distal of where the jailed wire goes away from the main branch. And that's where you have to recross. So there has to be a distance to it, because otherwise, if you chase the jailed wire, you will have a proximal rewiring and then eventually deform the stent. But of course, it gives you help in bifurcation stenting.
I have a small comment there. So nice presentation, thank you. Very, very informative models. So I think the models are important because we see the consequences of our actions. So that when we do something, something can go wrong in the vessel. And the angio is deceiving good in many cases. So the pot is very essential for the bifurcation to do it properly.
Absolutely. And by definition, the wire that you stented over is true lumen. So then very next step after you retracted your stent balloon is the pot balloon. This is the first thing you do as next step. And then you will not end up with the free hanging stent, which is extremely fragile. It doesn't need much to deform a stent. And if you pot it very nicely, you have a well-opposed stent, and the whole situation is much more stable and controllable. Fully agree. So there's a question from the audience about what would you say routine pot has become mandatory for almost all bifurcation stenting? Yes, it has. So pot is absolutely mandatory because of the nature of the bifurcation, the fracture law. And also the European Bifurcation Club even recommends to do just pot and not even touch the side branch if you're worried about side branch dissection. So you could just put the stent according to the distal reference diameter and do a nice pot. And as you have seen in my bench models, if you do a proper initial pot, which is distal at the carina, your side cell will expand tremendously and open very nicely towards the side branch. And this seems to be even enough. And then you do a little bit more proximal, the final pot.
Yeah, to make a comment as well. Thank you, Dr. Leibundgut. Great talk with many teaching points. You showed us in a very good way how details can make the difference in bifurcation lesions, how we treat it. Very nice, interesting shape for pot with a balloon, and I think interesting philosophy about how we finish our job with this kind of balloons. And I don't know if it's nowadays that we use more DCBs. It's if it has changed somehow the way we treat the bifurcation lesions, because it's now a trend not to put the stents, to use more for the side branch DCBs. And maybe you have to, I don't know if putting a DCB there change how we deal with these lesions. What's your opinion?
Yes, great comment. Thank you very much. I think I have a very distinct opinion about that. This is an old bifurcation case, and also my involvement in dual stenting is very ancient in the meantime. And it's kind of disappointing because I loved all these dual stent strategies and they're pretty much gone. I don't remember when I have done the last time a culotte, and I even in the meantime feel a little bit awkward when I put so much metal there. Therefore, I think, and this is also a bit the opinion of many people in the European Bifurcation Club, the provisional stenting strategy is the cornerstone of all bifurcation treatments. You go across the side branch. Then, as I said, you do the pot, you open the side branch if you think it's necessary, if it's important enough, let's say if it's the left main, and then you reassess, like in the EBC main trial. If there is flow in the side branch, no need for stenting. Basically, the same principle holds true that we do for de novo lesion in small vessel, which is recoil more than 30%, less than TIMI 3 flow, or flow limiting dissections. If you have one of these three things, you must put a stent to the side branch, and in provisional manner, you can do it. If the bifurcation angle is big, you can do a reverse T. If it's shallow, you can do a tap. It's very shallow. I propose to do a culotte because you don't want to end up with a long neocarina. But this has all been based as a continuum, basically, on the provisional strategy. But most of the time, and even in this scenario, I would just put the DCB in the side branch because the dissection may be a little bit big and I'm worried about nice healing, and that's it. So my dual stent bifurcations are down to 5% from what I've done 10 years ago. And therefore, also, final word, I don't do DK crush because you embark in a dual stent strategy from the get-going. So you committed to a dual because you put your first stent in the side branch and you cannot adapt. That's why I'm not doing DK crush, although the data is phenomenal.
Thank you.
Yes, I think for sake of time, we have to go on. And we still have time to discuss this during today's webinar. So I would like to invite Anita Paggi to share her screen and present her talk.
Okay, can you see that?
Yes.
Okay, sorry, just a minute. Sorry. I'm not that skilled in that things. So, okay, sorry.
It's on the bottom.
I just, okay, because I don't see my screen actually. I mean, I see I have condivision, but I don't see it. I see you still. Okay, just a second. I mean, before, of course, it was working nicely, and now I don't see my presentation. Okay, so you see that in presentation mode now, sorry?
Perfect, that was just perfect.
Okay, thank you. So, sorry for my delay. My presentation today is about scoring balloon and pot. I think that I will go through some practical cases in order to discuss what kind of tool we need for good modern PCI. So I start with a case, a 65-year-old lady with some cardiovascular risk factor. She presented in May in our hospital for an STEMI with inverted T waves in interior leads, and the echo showed a preserved ejection fraction and apical and mid-distal anterior hyperkinesia. So we scheduled her for coronary angiography the following day because she arrived late at night. And this is the basal angiogram, and you see a still frame. So we have a nice, interesting focal lesion of the middle AD. And we also have to consider, we have these two very interesting side branches because we have two diagonal branches which have some discrete diameter and also some good territory of perfusion. So what is our strategy for that PCI? When I am involved in bifurcation treatment, I always use a 7 French catheter from radial axis. It's pretty easy to use. And in case just I get in trouble, I have some more space for devices. 3 wires. It's like sort of a double bifurcation with no side branch disease, at least some mild disease, but not heavy disease. but these are both important branches I really wanted to preserve. So as you were saying just a few minutes ago, my strategy was a provisional strategy because I really just wanted to stand the main branch and have a provisional strategy for the sides. So my first thing was to do a pre-dilation. I generally use non-compliant balloon for pre-dilatation also. A 3-0 balloon actually at 20 atmospheres. You see there, I have some improvement, but if we have a closer look at also the balloon, we see we have some spot of under expansion, and also the angiographic result doesn't seem to be like that brilliant. In these cases, also if I don't use imaging, in my experience, I can perceive we have some spot of calcium, some seems to be proximal, but we have some calcium, and also we have fibrosis. And fibrosis is also important when we treat a lesion because of recoil. And so I decided that my next step was to use a wedge and non-compliant balloon, which is a scoring balloon with a nitinol wire running outside the balloon at 16 atmospheres. You see on the left, we have 3 different views, which confirm actually that the expansion of the balloon is nice. And also the angiographic result seems to be really better than the non-compliant balloon. So we had a non-compliant at 20 atmospheres. We have a wedge at 16 atmospheres, but the result seems to be pretty much better with the wedge balloon rather than with a non-compliant. So going a little bit deeper into the wedge is a non-compliant balloon. So it has all the characteristics of a non-compliant balloon. So you choose the diameter and it sticks to the diameter you choose. It has a very good crossing profile. And the main characteristics is the nitinol wire that runs outside and allows you actually to push more and to work more on the calcification, but also, and not only on calcification, I would say, but also on fibrosis. Because if you treat fibrosis properly, you have to deep treat that fibrosis if you want to have a good lesion preparation. And we know that nowadays, lesion preparation is crucial to the long result of the PCI. So you see there, we have a very wide range of balloons from 2.0 to 5.0, many different balloon lengths. So you can choose a very short if you need, or very long if, for example, for a distal long lesion. The nominal pressure is 12, but you can easily go up to 20, 22, and you still stick to the diameter as every non-compliant balloon. So I think this is a tool that really allows you to obtain a good lesion preparation in very different scenarios. In this case, it was focal, and I wanted to be precise, but it was a really good lesion preparation. You see the DS here implanted, how nicely it expands also before post-dilatation. And then we come to post-dilatation. Of course, we have the 2 diagonal branches. So as it was just explained, you have to be precise on the carina, and the diagonal are also close to each other. And so the pod balloon, in my opinion, was the actually perfect choice, because I could stick to the carina, the first one, the second one, in a very precise way. And I could finish the work also with a good edge stent dilation, as you see in the screen from the stent boost. The pod balloon, as we already said, is a particular balloon, is a non-compliant balloon. And the main characteristic is the shoulder. We have many types of non-compliant balloon. The range of the shoulder length varies a lot, but it ranges through at least 2.5 millimeter up. And so the pod balloon is pretty much different because we have a shoulder of 0.6 millimeter, which is great because you want to do that. I mean, you want to be precise in the carina, as it was previously said, But if we concentrate a little bit more on the proximal edge of the stent, we want to be precise on the proximal part of the stent because it is needed that the edge stent has a good expansion and apposition. And if we have a long shoulder, we have sometimes the first situation where we are too distal with the balloon, so we have under expansion of the edge. On the other hand, sometimes we want to achieve the edge dilatation, so we are too proximal, and we have the risk of edge dissection, which was really common. But with the pop balloon, we can be very precise and obtain both expansion and also be safe with no edge dissection. You can see there some different brands, and you can see how the shoulder length varies from 2.5 to 5 millimeter against the 0.5 millimeter length of the pop balloon. And so, which are the main characteristics I want to underline? The precision you can have using this balloon, both for the carina, both for the edge stent dilatation. It is not a slippery balloon. I mean, if you have a situation like left main, you generally use short balloon because like you need a 6-8 millimeter balloon, and you need them to stay just where you put them. They are not slippery at all. You put them in a place and they remain there. So you have no edge dissection because of the shoulder, and you can also maximize your DS tapering because you can really go up to the very edge of the balloon. So this was done. Of course, the kissing was done as well. And this is the angiographic final result, which to me seems pretty good. So I'm going very quickly through a couple of cases because I'm running out of time actually, but I really wanted to underline the two characteristics of the wedge and the non-compliant. A second case, an STEMI, lateral and STEMI, also from the electrocardiogram and the echo. It is a lady. You see there we have a diagonal branch with a focal stenosis. The diagonal branch is not that much big, but it has a good territory of perfusion. We really don't want to stent this type of lesion in modern PCI. We don't want to compromise the LAD. So we want to keep it simple but effective. And so again, I started with non-compliant 2.5 by 16 atmospheres, ended up with actually no lesion preparation and somehow some probably a little dissection. But so I'm not satisfied with that. So we decided to shift to a wedge non-compliant 2.5-15 at 16 atmospheres and to complete with a drug-coated balloon. You see how nicely the wedge expands, and this is the final result. We have a good lesion treatment, and this is the screen, and we have a small dissection, which, as we said, is a totally acceptable dissection because it's not flow limiting. We have less than 30% stenosis left, and I think that this was the best treatment for that diagonal branch. And eventually, a male case with anterior hyperkinesia, anterolateral ST depression, unstable angina. This is the coronary angiography. We have a proximal LAD lesion. It seems to be like an ulcerated plaque. But if we look at the angiography, we have some calcium spots, and that was really confirmed by the IVUS. So we have calcification also to treat. So in this case, I decided to go straight with a 4.0 wedge non-compliant balloon at 20 atmospheres because I really want to treat that calcium. And this is the result after the dilatation of the wedge. Very nice result and very nice IVUS result with crackings of the calcium. And we were ready to stent, and this is the stenting, and this is the angiographic final result, which also appears to be good to me. Sorry, for the sake of time, I go straight to my take-home messages. I think the modern PCI requires a correct approach and correct tools because we want to achieve a long-lasting PCI result. We cannot just say, okay, the vessel is nice now, what about 6 months? We want to have a long-lasting result. So these two tools, wedge and non-compliant, are non-compliant scoring with an external nitinol guide wire. It has an excellent crossing profile, very trackable, and also allows you to treat also distal and small vessel, calcified, and would add fibrotic lesion in an optimal way. On the other hand, POT are excellent post-dilatation balloon, and for their characteristics, I think they are unmatched for Stent-Edge optimal dilatation, for carina treatment, and for DS tapering. So if you know your tools, you know when to use them. And I think that upgrades your daily practice, may also in routine cases, and moreover in complex cases with a good long-lasting result. Thank you very much for your attention.
Thank you very much, Dr.ssa Paggi, for this excellent talk and these very nice illustrated cases. Are there any questions from the audience? Not so far. I have a question again. I mean, you alluded it in your talk, but are you still, the debate is every day in my lab, do we touch the side branch or not? How is your opinion there? Are there certain sizes of side branches or segments that you say, I treat it, I do a kiss, or how is your strategy there?
Okay, so I think that side branches are pretty much important, but of course, not all side branches are the same. I mean, in the cases I showed you, they were pretty much important side branches. Again, I didn't want to stent if not necessary, as you said. So of course, if we have like a more than 2 millimeter, I think it is important to treat them properly. But I mean, unless you have a very, very small side branch where you maybe put a wire just to keep it open, so a keep it open strategy, like less than 2 millimeters. If you have a stent in the main and you decide to touch the side branch because it's like 2 or more millimeter, then you have to kiss. Even sometimes, I mean, it happens, I think, in real routine days that you have like 225 and you say, okay, it's good, I don't do the kiss. But if you dilate the ostium of the side branch, you have to kiss because, as you said, it creates a distortion in the main. So, of course, your main goal is the main branch, but if you dilate the sides, then you have to kiss. On the other hand, there are some small branches you just want to keep open. And so sometimes I don't touch, I just put a wire, and if everything is fine and they're less than 2 millimeters, I don't touch them. Actually, it's my daily practice. But if you touch, you have to kiss because of the good results of the main.
That's a good and easy to remember statement. The other thing is what I experience a lot of time is that when the PCI starts, all the branches are relevant and important, and as soon as they start closing down, they become less and less important by the operators.
Yeah.
Because I understand it's difficult to rewire or to reopen an occluded side branch, and it can become dissected and you make things worse. Having said that, do you have any tips and tricks to reopen a side branch when you had unfortunately done the pod to distal, or you oversize your stent and you have a carina shift and the side branch occlusion?
Well, of course, side branch occlusion is, it happens. It is not wanted, but it happens. And if you have to rewire, I think you have to. My practice is to use a non-hydrophilic wire at first, to take my time and just try to do the crossing and reopen. Sometimes what happens is when they close it's sometimes because of the carina shift, but sometimes it's also because of we have some little dissection of the edge of the side branch. So if I perceive there might be dissection, I sometimes take like a microcatheter and a SUA 03 and try to rewire with that guide, which is really soft, doesn't dissect actually, and sometimes it is a good wire to run across some ostium dissection of the side branch. So this is one point. Some other point with difficult recrossing of the wire branch of the side branches is also the Miracle Neo wire, which is non-hydrophilic tip, and then it's hydrophilic. So you just have to engage the ostium and then it slips through. And I found it useful in some occasion. And sometimes, if I'm not sure the part was done properly, I redo a proper part and try again. Of course, sometimes you have to just, I mean, my mentor once said, Dr. Bramucci, I don't know if you know him, said that people live with the proximal and mid LAD and not marginal and diagonal. And this is a take-home message at the end of the day. I mean, of course, the proximal LAD is more important generally than a side branch. But if you can do some work to try to reopen, it's always a good point. Of course, if you mess up too much, then sometimes you have, as you said, they become less important by the running out of time.
Yeah, if I may summarize, I think repot more proximal, very important step. Never forget that. That helps a lot. And the other messages I got, you start with very benign wires, blunt wires, low tip load wires. Don't go too aggressive, because when you dissect, everything is done and lost. So I think for the sake of time, I would like to introduce our next speaker, Olli Kajander from Tampere in Finland. He talks about RevoEdge and complex lesions.
Okay, so thank you very much for the invitation to this webinar. So I'll start my presentation. Okay, the previous has to stop sharing. Okay, now it's good.
I'm sorry, I always forgot that. They already told me later. Sorry.
Can you see my screen now?
Okay.
Can you see my screen now?
Yes.
Yes.
Yes. Sorry.
Okay, good. And you can hear me?
Yes, all good.
Okay, so thank you very much. And I'll talk about RevoEdge and show some cases treated with that. So I come from Finland, city of Tampere, which is in the southern Finland. The heart hospital here is one of the university hospitals. Shortly, we have like more than 13,000 invasive cardiology procedures, including 1,200 PCIs and 300 TAVIs. So RevoEdge has brought many advances to the field of scoring cutting balloons. Because of the nitinol, the welded cutting plates, it's very flexible and deliverable in complex lesions. And it has high cutting power, which is measurable, and also enhanced visibility compared to the competitors. The thin wall double layer balloon structure gives it a lower crossing profile, and it's less prone to dog boning, and has a small folded profile as well. And the size selection is quite wide, beginning from 1.5 millimeters. My patient cases begin with 82-year-old female who presented with a non-STEMI, an infection. She is a high bleeding risk patient and has some comorbidities as well. There is a quite tight lesion in the mid-LAD, and you see this ectatic coronary disease, also some diffuse disease in the distal part. And we aim to treat that tight lesion in the LAD. after a conventional NC balloon, there was quite a lot of elastic recoil, even though we used high pressures. And we didn't want to dissect the vessel distally. So we used RevoEdge 3.0 millimeters and did some 2 or 3 dilatations. And after RevoEdge, we see that there is clearly less recoil, but no antegrade or retrograde dissection that we wanted to avoid, because we aimed at a focal treatment strategy in this case. And we used 3.0 DCP, and the final result is very good concerning the tight calcified lesion and the diffuse disease. So we see that the luminal gain is improved with the balloon, and now it enables us to treat it with DCP, and also all the side branches are patent. My second case is a 78-year-old male who was hospitalized for unstable angina, has a normal echo, and he has some significant cardiac history. So some PCIs, then a cabbage 4 years earlier, and then the native obtuse marginal PCI 10 months earlier. And unfortunately, there is a tight restenotic lesion in the very tortuous stented LCX. And we managed to get, by increasing balloon size, to get there an NC balloon with the aid of guide extension catheter. And we used high pressures with the NC balloon, but still there was some recoil. And we wanted to get better preparation, but we were not sure if we can deliver a balloon there. And we tried to deliver RevoEdge. We also had the guide extension ready, but actually we didn't need it because we could deliver the RevoEdge 3.5 in the lesion. And we performed some dilatations in high pressure, 16, 18 atmospheres. And after RevoEdge, there was much more luminal gain than with the NC balloon. And because of the edge disease, we decided to deliver another stent in the distal part to cover it. And there we needed the guide extension to deliver, because it was so tortuous, almost like 90 degrees bend in the proximal vessel. The final result was good, and expansion is 100% almost, so very good result for this very complex lesion. And I come to my third and last patient case, who is a 78-year-old male. And this is an elective case. The patient has severe New York Heart Association 3 dyspnea and normal left ventricle, but there is borderline severe aortic stenosis as well. And he has also some significant comorbidities, as these complex patients often do. Our target was a proximal RCA subtotal occlusion, and when getting more angiographic images during the PCI, we realized that there is also a mid-RCA CTO, which was quite short. And with the help of dual catheter injections, we were able to use the antegrade wire escalation strategy and get the vessel wired. As in this CTO vessels, you have hard calcified lesions all over the vessel, and so was the case with this patient. So especially in the very proximal part, as you can see, there's a bulk of calcium. So there was under-expansion, recoil in the proximal vessel, and we ruptured even some balloons, NC balloons there, but we're not able to get good preparation. At this point, the vessel dissection is quite extensive, and it's not ideal for rota or orbital atherectomy at this point. As we can see in the IVUS, this point we were able to get the IVUS catheter in. So there is eccentric nodular calcium, which is very thick, also from the angio. So as a next result, we took 3.5, and we performed several dilatations in the vessel, first going from the proximal to the distal, and then we went out and went in again because it's possible with this balloon. So we tried to do as much cutting as possible in this very calcified lesion.
Hello?
Second, it's a little bit stuck.
Okay,
now I lost my screen. So,
okay.
So let's see, just a second. Okay, now I'm back. So I can continue. And can you hear me again?
We can hear you, but the slides are kind of frozen.
Okay. So let's see if I can go to my result slides. Just a second. Can you see now my screen and the slides?
Yes, it's still the screen with 6 images, but they're not still frames. I think it's
okay,
just
because my screen is now rolling good, so there's something with the connection.
So,
just a second.
no worries.
So
maybe in the meantime, while you solve this, we can answer a question from the audience. They're asking you or us as a panel, just take your time, Olli, to fix the PowerPoint. It's no problem. Is what type of lesions that you're scoring or cutting, if there's any specific difference. I think the person is talking about the plaque morphology and plaque distribution, which is only visible, of course, in intracoronary imaging, either by IVUS or OCT. And then according to the distribution of the plaque, are you choosing scoring or cutting differently, or what is your take on that?
Yeah, I think it's a very complex issue in a way that we have some algorithms that guide us through the calcium modification, and mainly I prefer to use for the superficial calcium, I prefer to use the rotating devices first, and also when there is some nodular calcium that I can see that I can hit it with the wire, so I use the rotablation or orbital quite much. But in these cases that you have extensive calcification, I've noted that only IVL is not very efficient. So in many cases we use cutting balloons combined with the IVL for these very extensive calcified lesions. But mainly if there is superficial lesion, we use a lot of rotablation.
Yes, I mean there's tons of algorithms out there about calcium modification. Most of them are based on expert opinion and also a little bit influenced by devices available on the market by companies, of course. Unfortunately, we have not really finally solved the issue. As you're all familiar, there's some indications from imaging with the rule of 5 from OCT, other rules for IVUS, which help to guide us. We will probably also see in the future single photon counting CT information, as Carlos Collet presented some data about plaque density. So there's this like famous 1K plaque, which is deliberately or allegedly not dilatable. So there you need to thin out the calcium, make it thinner in order to break. And we will see many more data, hopefully in the near future. In the meantime, the device market, in my opinion, exploded. I just recently saw a presentation about 8 or 9 cutting balloons on the market, as we had previously only one, the Wolverine. They're now exploding, and we're learning more and more with imaging and use of these devices. But there is no one single device that can treat everything. So it's a combination, has to do with imaging, to understand the distribution of the calcium. Then also during the PCI, we need to do re-imaging to understand the mechanism of action, what happened, what we have to do more in order to have a good expansion of the lesion. But I think we all agree that lesion preparation is key and has to be meticulously done for both drug-coated balloon and stent use in these vessels. So how is your presentation evolving?
Yeah, I think it's now working, so I could try to.
Okay.
Can you see now my presentation?
It still looks frozen to me. It's still the same image as before.
Okay, so then it's something to do with the connection, because my computer screen is now working perfectly fine. So I will go to the end of my procedure, my presentation. So we after the RevoEdge in the calcified RCA, we got a very good expansion, and also in the proximal part, and with the IVUS we saw an MSA of almost 10 millimeters squared, and I consider that's very good result for this very calcified lesion, and this was without any rotating devices. And all the side branches were patent as well, and no recoil. So I will end my presentation just by stating that we were used to the idea that we need several balloons. We need a deliverable scoring or cutting balloon, and then we need an effective cutting device as well as we need high pressure dilatation. And all these devices, it would be nice that if they would be reusable in several lesions. And I think in RevoEdge we have a good device for all these 4 components of the complex lesion preparation. So thank you very much.
Thank you very much, Olli. So if you unshare the screen, I think we should be back.
Yeah, just a second.
For a brief discussion. So I think Anita, Ioannis, do you have any comment on Olli's presentation or question?
Actually, well, yeah, I have just a brief comment, if I might. Actually, I found terrific the performance of this balloon, because in the cabbage patient there was really heart tortuosity, and the fact that the balloon was delivered without the guide extension is pretty much impressive. And also the RCA case, it was a tough and complex case. And the fact that you said that the balloon is actually reusable, I mean, you can use it in different lesions, is also one thing that impressed me, because by now my experience has been with the Wolverine balloon, and actually the durability was quite a concern. And also, once you dilate in one point, of course you can go proximal, but never distal, and it's impossible for me to reuse it, for example, in another vessel, in another lesion. So these two concepts, the deliverability and the fact that you can reuse because of its profile, are characteristics which pretty impressed me.
Yeah, fully agree. I can only reinforce that. The blades actually on the cross section, I think you showed that, are exactly the same height and also angulation of the blade as the Wolverine. It's 0.21 millimeters. So the depth of the cut is exactly the same. The difference is that it's not glued on the balloon. I think this makes it very much refoldable because the balloon is kind of independent from the blade. And that, I think, accounts for the really nice refolding and reusability of this device. And of course, it's a true non-compliant balloon. You can go up to 20 atmospheres, given the potential of 4 to 8 times increase of focal pressure because of the blade. You can imagine that at the blade level, you have 80 millimeters of 80 atmospheres of pressure, very focal and controlled on this balloon. Ioannis, you also wanted to comment?
Yeah, just one comment here. I totally agree with your comments and what Dr. Leibundgut mentioned, that we have so many weapons now in our cath lab for these lesions. So we have to combine it, depending on the characteristics of the plaque with intravascular imaging. We can see how deep is the calcium or how many degrees around the vessel. And after that, we could use the best weapon. And we have to, first of all, we have to cross. As you know, many of these lesions are uncrossable, and we cannot deliver these balloons. First, we have to cross. So we need the good support with big guide catheters or mother and child techniques. And then after we cross or doing a atherectomy, then we have to dilate in the best way to prepare the lesion. So we have so many weapons, so many tools like IVL or now cutting balloons. As you mentioned, many cutting balloons are coming in our cath labs. And this webinar, I think, can show to all participants and all the viewers how we can deal with these lesions. And of course, it's a little different area from what it was some years ago. And we know we all deal with three vessel disease, very calcified lesions, old patients. No one wants to go to the cabbage. So we're trying to have a total revasc with complete revascularization with our tools in cath lab. So I think nowadays we can deal with all lesions and achieve the best outcome for our patients.
Yes, I fully agree. And we're lucky to have good industry partners to provide us with all these very nice and very innovative products. So I would like you now, Professor Tsiafoutis, to present your case. I'm sure since you're a complex CT operator, we're going to see a lot of calcium, and we can afterwards discuss more about these cases.
Yes.
I'm looking forward to your presentation.
Thank you very much. I want to thank you all for this webinar, and let's see some cases. I was called to have some cases with RevoEdge and the microcatheter ProNavi as well. And so this is going to be our cases that we'll show today. We talked about RevoEdge and how this high pressure catheter balloon dilatation catheter works. We have all these sizes, and this is our technical specification of the catheter. Let's go to the case, not stay too much with this. And then you see there's a bifurcation lesion with LAD, a diagonal branch. We wired both branches. We did the NC balloons in both branches. Now we try to do a reverse tap technique. First to put a stent in the diagonal branch, and after that stent in the main branch and rewire and do the kissing balloon. You see there's a dissection in the LAD. We inflated the stent in the diagonal branch, and at the same time the balloon to make a new carina, and we took a big stent to inflate for LED, but you see there's after the inflation there's immigration of the hematoma from the dissection distally. This is a point where you can use the cutting balloons, as you know, and we used there, but unfortunately it was not recorded, but we did an inflation with the cutting balloon. You see the balloon is there, the RevoEdge balloon, and the hematoma disappeared. We made fenestrations, as you know, with true lumen, and we had a fine result after doing a drug-eluting balloon with a defined final result. This is a case with multiple stenosis in RCA with many stents. Came from another cath lab. After doing NC balloon inflations, we decided to use the RevoEdge balloon. Here it is, with gradual inflation. We had to use a guide extension because it was really tough and difficult to advance our tools. And after that, we put a stent, post dilatation, with a very nice result. And with the divus, let's see. And this is another case with a calcified lesion of LED, with a suboccluded LED with a tough lesion. We used the LC balloons, you see, and after that we used the RevoEdge balloon. I think it was 2.5. You see, it's really tough. After using many NC balloons after that, we inflated the stent. And had a very good result, finally. And some cases with Pronevi microcatheter, you know, there are two types of this catheter. One is 1.7 with straight tip, a very small profile that we can navigate it and torsions and complex anatomy, and the Pronevi 1.9 with tapering tip. This is the entry profile comparing with other microcatheters. And so let's see some cases. This is a LAD CTO case. It has an ipsilateral septal collateral from septal to septal. We use the Gaia 3 to go antegrately. We had no good result over subintimally, so we switched from septal to septal retro with the Pronevi microcatheter. We did an injection from the microcatheter and we see the connection from septal to septal. And the distal thing, the problem there was that the septal was going to the distal cap, so it was really difficult to go retrogradely. It was really difficult, but we managed with the Pronevi catheter to drive Gaia retro in left main. And we went into the left main and by doing IVUS, we reassured that when through lumen. After that, we did the tip-in and went antegrately with the micro, and by using a dual lumen microcatheter, we went the gladius, we drove a gladius distally. It was the final result. Another case with LAD CTO. We use the Pronevi 1.9 microcatheter, the filter XT wire. Find the way distally, inflating balloons, and had after all the procedure had the fine results. And this is a case with an obtuse marginal CTO case with again the Pronavi 1.9. Gladius CX went distally, had a little extravasation, but no no effusion. The patient was just in the wall, and we managed to go distal and finally did the investment procedure. Now we're waiting the patient for next check. So the result, the take-home message is that to have that's like cat and balloon weapon are useful in everyday practice in cath labs that we deal with these cases, and RevoEdge high pressure cat and balloon may support us to achieve the best outcomes. And the microcatheter Pronevi with 2 types may be useful for demanding CTO cases as well. Thank you very much.
Yes, thank you very much, Dr. Tsiafoutis, for these great cases. I have one question for you. Since you're a CT operator, I assume you also do anti-great dissection reentry strategies, and you end up to be extra plug quite a few times in your procedures. How is your opinion about cutting balloons in the subintimal or extra plug space? Are you using those? Are you basing that on imaging, or is this something you're avoiding?
Yeah, it's an issue that I don't know if someone can have a straight answer about that, because depending when you're afraid that you are very really to adventitia, you have to be careful, because after using a balloon like that, you may see a perf or you may have a result that you don't want it. But since we have intravascular imaging, you can decide it. But I'm not, I don't really use it in subintimal space. I don't know your opinion about that. But there are cases like how I showed the evacuating an hematoma from the subintimal space and they treat the vessel. It may be useful, like the case I showed you.
Sure. Well, since you asked my opinion, I must say it is an opinion, so it's
Yeah.
I don't have much experience, but usually try to base my opinion on like physical understanding or try to understand what's happening. So just for the audience, if you're in an extra plug space, what we call it now, or previously subintimal, you think about your calcium of the true lumen is on the one side, and on the other side, depending on how far out you are in the media, there is only adventitial tissue. Adventitia is very compliant, so it will probably just expand, and your focal force that you have against the plaque or the calcium will be still very effective, in my opinion, on cutting balloon. And I actually have the idea that cutting balloons could be even safer in their extra plug space than a regular balloon, because you can have lower atmospheric pressure in the balloon, and then still have a very high focal force on the calcium, and hopefully then have a fracture in the calcium. Having said that, the risk of perforation in the extra plug space is more related to balloon size and overstretching the vessel architecture and rupturing the adventitia. So I deliberately take cutting balloons in extra plug space, but I do undersize them compared to as true lumen crossing. But again, this is an opinion. And
Very nice comment about sizing. Yeah, it's very important to have not a big size, because this may be catastrophic.
I think the problem
Exactly.
there is the pressure distribution in the subintimal space. So you want to exert the pressure to the plug, but when there is no force opposing it from the intimal side, so then you cannot deliver force to the plug. So I think that's the problem with the subintimal cutting as well.
I think there's a
Exactly.
question about the two types of Pronavi microcatheters. I usually use the smaller one, the 1.7, for going to collaterals, septals, or even sometimes epicardial. And the other one, the 1.9, the tapering shape, let's say the tapering shape, I use it for going under greatly most.
Okay, great comments. Since we're running out of time, I want to ask a question from the audience, which is how do you choose the 1.7 French versus the 1.9 French Pronavi MCs in your
Yeah,
practice?
that's what I said now, but I usually use the 1.7 for collaterals, going for septals or even to epicardial sometimes, and the 1.9 most for undergrade cases.
Even in septal collaterals where you have like a very calcified right coronary, for the retrograde, you would still use the 1.7. Is that enough
Yeah.
robust for crossing the calcium, in your opinion?
Yeah, I think so.
Okay. Yeah, me too. Very much the same opinion, because first of all, I want to cross the retrograde pathway. I do not want to harm the collaterals, and usually the tip is not different, and the robustness is good enough to even cross calcium. And of course, if it's too much calcium, we're gonna go anyway around it with the subintimal tracking techniques, and there you don't need a very robust microcatheter. So thank you very much for all your contribution. I think it was an amazing webinar. All the presenters presented very important aspects of these devices, from BrosMed, the pod PCI balloon, the RevoEdge cutting balloon, and Pronavi microcatheters. Showed how versatile they are, and that they're absolutely ready for complex PCI, including CTOs, bifurcations, and calcified lesions. With that, I want to conclude and thank you again for your early commitment and your excellent talks, and have a good day.